This conference will now be recorded.
So good evening, everyone, and welcome to AnCan's virtual chat support group for low and intermediate risk prostate cancer for Monday, May 11th, 2026. Welcome to our first-time visitors and to all of our returning friends. I am your moderator for this evening, Stuart Jordan, and I am assisted by Bill Franklin and Boykin Jordan. And we also have Rick Davis, our founder, here as well. A couple of initial comments just for everyone on the way in. We like to remind everybody that this is a peer-to-peer support group, and nothing that we are sharing here today should be construed as medical evidence or advice. We're here to share our collective experience and answer questions, and hopefully give you information to take back to discuss with your doctors. Before we begin, we'd like to thank our sponsors, Novartis, Blue Earth Diagnostics, and Foundation Medicine. At AnCan, we actually have multiple prostate cancer groups for attendees. We have a group that focuses on active surveillance for those who are considering or have opted to postpone or avoid treatment. Tonight's group addresses low and intermediate risk prostate cancer for men who are planning for or have had treatment. A note, we do not address recurrence in this group and instead invite you to join our high-risk recurrent and advanced prostate cancer group, which meets tomorrow evening at 6 o'clock East Coast time. And we also have special groups for veterans, men under 60, gay and bi men, and also is the new European group. So we try and meet folks wherever they are in their journey. With that said, we will go ahead and get started. And as mentioned, what we like to do is we start with our new folks who are joining us for the first time. And for you guys, just to let you know, the process of what we like to do is we have a short set of questions that we will start by asking you just to get us up to speed on your situation so that then we're in a better position to talk to you, hear what you have to say, and address your questions. And with that said, let's get going. And Charles, you were here bright and early, so you get the first step. And so, how old are you, Charles?
61.
61. Okay. And you said you live in Alabama.
Correct.
Okay.
And I'm going to City of Hope in Noonan, Georgia.
Okay. And Charles, are you a veteran?
No.
Okay. And how did you hear about AnCan?
Mayo prostate group, especially Jeff Marchie. He's fabulous answering people's questions and giving info and everything like that. And I've watched a lot of videos and participated in some of the webinars already.
Cool.
Because of him.
That's great. And I saw you put your email address in, so we will get you on the list to get our notices about future meetings. So let's start at the beginning. When were you diagnosed and how did that come about?
I had the MRI and biopsy September of 2025.
Okay, let's take a step back before that.
So I got a 4 PSA on my annual blood work in June of 2025. So I went from a 2.7 or so to a 4. So I immediately scheduled the first appointment with a local urologist that I could. Dree didn't find anything, so I did a 4K blood test and an MRI as the next step.
Okay. And
so the MRI was in September of 2025. It showed a PRADS5 lesion approximately 1 by 1.2 by 2 centimeters long.
Okay. Just the one lesion?
Just the one lesion.
Okay. So you were saying, so you had the MRI and you're
And then I had
done. Go ahead.
and then a biopsy with 5 cores of 3+3.
Okay. Going back on your biopsy, was that a
It was a
transrectal
targeted, uh,
or transperineal?
I think it was transperineal. I did not
Okay.
ask and didn't know to ask at that point, but I think it was
Okay.
transperineal. Um,
Okay.
it was a
And
fusion biopsy.
it was a fusion. Okay. So
Correct.
that's good. And so you're saying that the result of that biopsy was 5 3+3s.
Correct.
No, nothing greater than that.
On that biopsy.
Oh, so
I've
you've
had
had more. Okay.
follow-up.
All right, when was that biopsy?
The follow-up was in last month in April of 2026.
No, the first one.
Oh, September of 2025.
Okay, so you had that one. They found a bunch of 3+3s, and so what did they say? Just let's wait and do it again, or what happened?
Yeah, so that was with a local urologist. So I set up a follow-up second opinion with City of Hope in October of 2025.
Hmm.
So the MRI indicated possible extracapillary extension. So that was a bigger concern versus just the 3+3. So the radiation oncologist felt like the PRAS5 lesion may be higher than the 3+3 grade. And so at that, we were doing active surveillance, so I did a decipher test in October of 2025. It came back a 0.48. So with the possible extracapillary extension and a mid-range decipher, the radiation oncologist was able to get a PSMA PET scan approved. I did that in November of 2025, and it showed only the one lesion lit up. So it is confined to the prostate based on the PSMA PET.
Charles, I thought you said that your PI-RES was a 4. Was it a 4 or a 5?
No, 5.
A 5? Okay. I must have misheard.
Okay, so at this point, at that point, you had the one biopsy and the PET scan. And so what happened after the PET scan said it's all still contained?
So the urologist and I discussed, is it being likely that there was higher grade in that lesion. We did a repeat biopsy, MRI and biopsy in April of 2026 at City of Hope.
Okay, and what did that say?
So it had 4 cores of 3+4 and 1 core of 3+3.
Okay. Now on these 3+4s, how much 4?
So 1 core of 10 millimeters in length, 95% of it was cancer and 30% of it was 4. And another core, 17 millimeters long, was 95% cancer and 10% 4. And the other 4s were in the 5 to 10%. So it was not heavily 4 yet, but the lesion's big enough that almost all of that core, a couple of the cores were 90 and 95%,
Okay.
grade 3 or 4.
Now, were there any other mentions on that report about cribiform or any of
No,
the other?
no, I've not had any cribiform or anything like that
No
show up on
PN.
either one of the biopsies.
Okay. Okay. Now the next question is have you had a second opinion on this second biopsy that's showing
I have
all of
not
the
had,
plus fours?
I have not sent it off to anybody else to look at it. Now, City of Hope obviously had a second reader look at the biopsy, but I have not sent it to Dr. What's his name in this
We
Epstein?
Yeah, either Dr. Epstein or
Right.
Dr. Ming Xiao.
No.
We recommend in a situation like yours to get a second opinion, and the reason being is, you probably have, if this turns out to be correct, that there's no major regrade up or down, you've got enough cancer that you're probably looking at treatment and having the best picture of what's there before you start any treatment conversation is going to be, will be important.
Yeah, that
So
makes sense.
we really encourage you to contact. We've put the stuff is in the chat.
Yeah, no, I know how to send it off to Dr. Epstein. I've looked it up, and I can do that easily.
Okay, that we would really suggest is your next step to
Sure,
really
sure.
confirm what you've got, and then from there, you can start to move forward in terms of, questioning. If Dr. Epstein comes back and confirms that he sees 30+% for in that primary lesion, that probably is going to push. That's probably enough that most people are going to tell you that it does need treatment as opposed to continuing on surveillance. The other ones would all sort of fall into surveillance, except for the fact is how many of them that you have.
Correct. Correct.
So
I have, I appreciate everything that everybody says, and I've been very good at being proactive, and so that's a good plan. I have the prostate test, ultra test will arrive tomorrow at my house, the test kit. So I've met with a radiation oncologist after the biopsy, and I participated in the webinar on the 27th, and then I asked her about it, and she requested it, and I've got the kit coming to at least understand the radiation toxicity potential with the prostate test.
that obviously becomes good information when you get to the next step. So it's a simple enough test. Have you had yet, or has there been any discussion about any genetic testing?
So I did the Decipher test last November. It was a 0.48.
Okay. That test is measuring the potential aggressiveness of that cancer. The other thing that we're interested with genetic testing is whether you carry any mutations, either
Yeah,
that you're
no, I have not done the BRAC2 or BRCA2 or whatever, but I will follow up on that.
Yeah, so Stuart's suggesting germline testing to see if you have any inherited mutations.
Sure, thank you.
It's
It's on my list.
it's a saliva test, so shouldn't be hard.
All right, sounds good. It was on my list of questions when I meet next Monday with the urologist. I've already sent it to him to talk about that.
Okay. What other questions do you have?
Let me just clarify one thing there, Stuart, if I may. Charlie, are you familiar with the difference between when we talk about somatic and germline? Because that's going to come up with your urologist.
I wouldn't say I'm deeply familiar
Okay,
with everything.
that's
I have to
okay.
read up on it.
No, we're,
I
we're
mean,
going to help you. We're going to tell you
okay,
right now. So,
okay,
what Stuart is really talking about is germline. Your Decipher test was kind of a somatic test. And there's actually a backup to that test, which is really for research only. But you can order it, you can get hold of it, and it will tell you if there are any strange somatic players in there. With a 0.48, probably not. If you had a 0.95, we would say, well, we need to look and see what they see. I mean, we had recently a guy with a very high Decipher, and there was something. I forget the name of that test. One of the guys will know what it's called, but it's a backup research test available from Decipher. What we're really talking to you about is there anything that you might have inherited? And that's called a germline test. Okay.
I've seen a lot of Jeff Marchie's post on that, where he had his RP and then it's just continued to come back and all that. And
It turned out he found out he was BRCA2, which has been important. We want you to get that simple germline test. That's all.
Okay.
Because if the doc says, oh, well, we sent off, we got the Decipher, like you said to us, you say, no, I just want to make sure. Do you have any history? Any cancer history in your family?
So my mother had uterine cancer at about 40 years old, and a sister had colon cancer early 50s.
Okay. So that tells me a lot. That tells me a huge amount. That most likely on that side of the family, and you may not have gotten it, is something called Lynch Syndrome. Have you ever heard of Lynch Syndrome?
No, sir.
Okay, well, you can look it up. There's several mutations that are involved in that, and they are usually inherited, but they're not always inherited. Dr. Mark probably knows a little bit about Lynch syndrome. He's sitting in the room today because we see it very common in endometrial and uterine cancer, and an ovarian. Did you say ovarian as well, Umar?
No. It was uterine cancer.
And what was the other one?
Colon cancer.
And colon. We see it in, that's what sent me up. We see it in GI cancers like colon, and we see it in uterine cancer. So it's possible that the two of them somehow or other inherited a Lynch from one of their parents, but that may or may not have been passed down to you. But yes, definitely tell your urologist you want a germline test because you think there could be Lynch syndrome on your mother's side of the family.
Okay, perfect. Thank you.
Because one sister had colon and the other sister had uterine, and then he'll say, okay, no problem. Otherwise, he's going to argue, oh, do you need it? You tell him that, it's a slam dunk.
Okay, thank you.
Okay, and you need to rule it out too. You absolutely need to rule it out, because God forbid you do have one of those Lynch mutations, MSH. I think it's MSL1, MSH3, MSH6, I think, from memory, and there's a couple of others. Then you need to get much more regular testing for certain cancers like colon.
Sure.
Also, Charles, there's not a lot of doctors. This is my opinion. It's not scientific, but from what we hear, there's not a lot of doctors that are going to say, you don't need DNA germline testing. But if you perchance have one of those doctors that gives you a pushback, just be adamant and say, as Rick said, that, hey, there's BRCA and there's Lynch syndrome possibilities in my family, so my insurance will pay for it if you deem it medically necessary. And right. It's no skin off his back. He just has to say it's medically necessary and order you a germline test.
I think it'll go very well. So like my radiation oncologist, and she's been fantastic, had never heard of prostocks So I had already printed out information and told her what I'd learned on the webinar and all that stuff. And she took it and she looked into it and ordered it, and I'm getting the kit tomorrow. So yeah, thank you. I think it'll go very well.
So you said you saw our webinar, right?
I actually participated in it and asked questions about HDR and would the Prostatex Ultra with SBRT be enough of a simulation for HDR if I choose it? And she said it would, and that's what the doctor should order. So I appreciate y'all.
No, we're glad you were helped.
I think she said, don't shoot the messenger. I think she said she thought it would. It seems to work, but they're verifying it in Breaky.
Right.
Yeah.
Right. So, but we like Dr. Joanne, and we have to thank Dr. Mark for originally landing her for the first video, so that she did.
Charles, do you have any other questions for us for the group?
No, sir.
Does anybody in the group have any comments for Charles?
I was wondering about which specific lab you go to for that germline. I think different ones test for different
Oh, Ambry. I always forget the names of them. Invitae, Invitae does it. Ambry does a good test. Myriad has a germline test. Steve,
yeah.
do you have cancer in your family?
I do actually. My dad had, my dad and my uncle both had prostate cancer, and actually every sibling my dad had cancer. So I think I had bad genes.
What were the other cancers other than prostate?
Something myeloma. Some where it shows up all over your body. I don't remember exactly what it was called. And then the one
that's metastatic, and it could be from anything.
The other one was lung cancer, but she was a heavy smoker.
So no, I don't know. I mean, there may be, but I don't know of a strong connection between lung and prostate. But there are other cancers and other mutations that are inherited that can show that.
Yeah, I was negative on all of the 14 that they tested in
Okay.
So
Dr. Mark.
I didn't have one.
Mark?
Yeah, I was going to ask whether you had a chance to speak yet about whether they would use a gel or a spacing balloon, and that's something that you want to ask with them. And if they're doing SBRT, what kind of machines? Because not all the machines are similar. Some use a larger margin around the outside, and I'm not sure if they're using CyberKnife at that facility. If they are, that may be the one with the reduced margin there. Otherwise, in Tampa or in Atlanta at Northside, they have machines that will keep closer guard on the amount of normal tissue that get exposed.
Sure. No, I did not ask them what machine. If they do the SBRT, they would use spacer gel. We've talked more about HDR. Dr. Shakibnia, the City of Hope there, is very good at that. But if we get to SBRT, I would definitely ask a lot more questions about the machine and everything. So thank you.
Yeah, I mean, the one to look at is whether it's MR Linac or not.
Yeah, I mean, that's down the line for Charles right now. So if no one's got anything else for Charles, we're gonna move on to Stuart, the next guy.
Yeah, Glenn.
Hello, gentlemen. Yes,
Hi
my name is
there.
Glenn. Hi there. I'm up in British Columbia, Canada. In December of 2024, I had a PSA that went to 6. And thank goodness I get blood tests every year because of a senior's driver's license requirement. I still have a commercial driver's license. So they picked it up, and my family doctor at the time said, we'll just watch it for now. We're not worried about a 7. You're 74 years old or 73 years old at the time. So it was left. And then in December of 2025, just 4 months ago, 5 months ago, I ended up getting a PSA of 11.5. And at that time, I was referred to a urologist. And the first thing he did was he did a cystoscopy, had a look around in my bladder, and discovered there was no concerns in my bladder. My wife had had bladder cancer 7 years ago and was completely treated with immunotherapy successfully and has had no signs of it since. And then at that point, I was referred to a urologist. This was the urologist that did the cystoscopy. I was referred to an oncologist here in Abbotsford, BC, and they called up a PSMA PET scan.
At first they did the biopsy.
And an MRI. But sorry, I've jumped too far ahead. They did a biopsy in January of January 26th.
Hold on a second, Glenn. Hold on a second.
Okay, sorry, Rick.
This is Rick, and I'm so glad you made it to the meeting. I'm so glad Carmen got the message to you quickly.
Thank you. Okay.
I would like to put the ball back in Stuart's hands, because we do have a procedure. We can go through things bit by bit, and then it all follows in a nice way, and then we don't get ahead of ourselves.
Okay.
Stuart.
Okay. Yeah. Okay. So just to back up, Glenn, you're about 77 now.
No, I'll be 75 this fall. 74 right 70,
now. Okay, 74. Okay, and okay. So, and this all came about from the PSA.
December, yes.
Yep. Okay. And you started to say, did you have you had a PET scan, but you also had an MRI and biopsy. So let's talk about the MRI first.
No, very first thing was the biopsy in January.
So they did a biopsy before they did MRI.
Yes. The biopsy showed one sample was a 4 plus a 3 for a 7. And of the 10 core samples, 5 of them were positive for cancer, but only on the right side of the prostate.
Okay, you've got the 1, 4 plus 3. What were the other 9? Were they 3 plus 3s?
Yeah, 3 plus 3s. Four other ones were 3 plus 3s. 5 of them were clear. There was nothing in the other 5. And I assume that those 5 were on the left side, because the only ones that were there was 5 that were positive of the 10.
Okay, now so that's what's called a blind biopsy. Didn't have anything. They didn't have anything to go on when they started doing the biopsy, so they just were doing a random grid of trying to sample around the prostate to see if they found anything. In your case, they found one thing, but without any targeting. That biopsy is questionable in terms of how much information it's really provided you, other than the fact that they randomly found one significant sample. And do you have what do you have the stats on that 4 plus 3 in terms of how big that sample was, how much cancer there was? Now, obviously, it's more 4 than 3, but is it a lot or a little?
Okay, so I'm just trying to go through. I don't have this memorized, sadly. I apologize for that. So the one that was apparently the worst was it was 34 millimeters of the total linear scan, and total length of the needle core tissue was 95 millimeters. Percentage of involvement was 36% of that sample.
Okay. Let's jump ahead for a second because before we spend too much time, you had an MRI after you had the biopsy.
Yes, I mean,
First, I had a PSMA PET scan.
Right. Okay. But let's stick on the MRI for a second.
Okay. All right.
What did the MRI come back and report?
The MRI showed that it was confined to the prostate, and that's as much information as I really got from it
Okay.
from the lab.
Well, the question is how many lesions did they see in the MRI? Did they see one? Did they see more than one? And what grade was it? Or were they identified?
Was not aware of that information, Stuart.
Okay.
Sadly, sorry,
Okay.
I don't have that.
I would go back and ask for a copy of your MRI report, and you're looking for how many lesions they identified and what score, because they assign a PIRAD score between 1 and 5 that talks about how the risk of them finding the likelihood of them finding significant cancer. This is all sort of backwards because you've already had a biopsy, but because it's a blind biopsy, the reason why I'm asking and want you to go find out about your MRI is to try and get a hint as to how much other cancer that may have shown up in the MRI that they missed on the blind biopsy.
Okay. And sadly, I don't know how to even interpret that up here, and was not given any of that information when I left the MRI. All I knew was that they were then concerned about doing a PSMA PET scan, which is what they did.
Okay.
They
now
used
that,
so
MRI.
they used a gallium tracer. So actually, my wife just found the MRI. So non-contrast post-centrals multiplanar multi-sequence T1 T1 2 weight images were obtained in 1.5 Tesla magnet. Findings: 60 by 43 by 52 millimeters, corresponding to an estimated volume of 70 cc's. Motion degraded, hemorrhage mild, peripheral zone, local it's not posterior, it's prosterial, in the right midbrain gland apex, 4:15, 5:16, 17, 6:15, 9:16, size 18 by 11 by 14 millimeters.
okay. Do you see PIRADS, PIRADS, showing
Yes.
up anywhere?
Lesion overall PIRADS category, PIRADS 5. Very high, clinically significant cancer is highly likely to be present.
Okay. Is there a reference of a second lesion, or are they only seeing one?
Extra prostatic extension not identified. Distance from index lesion or any PIRADS 4.5 lesion to NVBs 3 millimeters.
Okay. Okay. The concern is anytime you have a blind biopsy is you don't know what they didn't find.
Okay.
And that potentially could have an impact on where what's necessary and where you go from here. So Rick, can you help me out here in terms of what his options are in Canada for trying to deal with the unknown?
Whoops, I didn't mean to put my hand up. I meant to put my camera on. There you go. It's very difficult in Canada. We don't have any other Canadians in the group tonight, do we? No. It's very difficult in Canada to push the envelope. We
Yep.
have 2 or 3 Canadians in the active surveillance group are probably a lot more knowledgeable of what you can get. The fact is, you've had a PSMA scan.
With a gallium tracer, Rick.
Well, yeah, the gallium tracer is mostly, well, they use a couple of others, but the gallium tracer is just fine. There's very little difference between the gallium tracer and the other one that they use for Pylarify. I forget what it's called. What's it called, Dr. Mark? What's the other one they use? What's that other tracer they use? But he's got to look it up.
Posluma.
Yeah. What's the name of the 17F?
Oh, I know.
Yeah,
Posluma.
right. So don't worry about it. Your gallium 68 was just fine. It worked fine.
But
now,
can I add just one thing on that? And that is that because everybody is saying about how the disease is confined to the prostate, and that's not an accurate saying. What we're saying is they don't see any outside. It doesn't mean it isn't out there. It means that the test isn't detecting it. And the test, they're really not as accurate as we all think they ought to be. So just be careful in interpreting what's said.
I think that what that PSMA, from what I've heard, is telling you is the likelihood is you're a good candidate for initial treatment. Okay. And that initial treatment should be the whole of the gland, even though I heard you say it's only 1/2. So don't let anybody be talking you into doing focal therapy on 1/2 of the prostate. Okay, that is not a good option for you because of your 4+3. Now, we don't really know where else or what else we see. And if you were in the States, we'd probably send you back and say, you know what? Maybe what we need is a targeted biopsy. And you might well get it. That said, you didn't do great with your biopsy from what I heard this morning. And
I did not.
And we're really sorry about that. And you're one of the 2 or 3% of men that does get sepsis. We would have dissuaded you from having a transrectal biopsy in the United States. We would have had you do what's called a transperineal biopsy, which some people are getting in Canada. I know the guys in Toronto have figured out how they can get a transperineal because the risk of sepsis, we think, is much lower, although there are recent studies that say it makes no difference. We don't buy that. We just don't buy it. So our view is that a transperineal is going to be much safer. I think what we have to do in your case is just say, yeah, Glenn's got enough prostate cancer that he needs treatment. And the question is, what is the best treatment that we can get you? Most likely it's going to be radiation-based because you're already 74 or 75. And in our view, and in the view of many, that's not something we would not want to be doing surgery. So I think we're probably in the same place you are, in that it needs to be radiation. It needs to be radiation-based. The biggest problem with the knowledge that we have from this biopsy is we don't know how big to make that field. Whether we just need to focus on the prostate or whether there's anything outside that could be a little bit dubious. Now, you're saying that PSMA scan didn't see anything beyond the prostate.
That's correct.
Right?
That's correct. And in addition to that, Rick, I also had a bone scan.
Right.
And the bone scan saw nothing outside of the prostate.
The bone scan is very, very unlikely to see anything in your situation.
Okay.
That even more unlikely than getting sepsis. However, with your 4+3, however, the PSMA scan is likely, and that's good. And you know, I think that we just need to verify, and maybe if you do you have a copy of that PSMA scan?
You know, it came in USB stick, and I also have. They actually sent me a CD disc of it as well. That's the only thing that I have.
How about the report? What you need is the PSMA report. And if you've got, we'll take your word, but I don't want you to find it now. Go, sit down. I don't want you to find it now.
Okay.
What I want you to do is find a copy of that report and send it to Stuart, who will put his email in the chat window.
Okay.
And we just want to take a quick look at that report to make sure there's nothing suspicious, because the docs tend not to discuss this with you. And you don't have the questions to ask when you go in to see them. And so I think what we should be doing is talking to you about what have they put on the table for you as types of treatment, types of radiation treatment.
So the oncologist I meet Friday, 4 days from now.
Radiation, is that a radiation oncologist?
Yes, she's a radiationist. It's a female doctor, and she talked about the options for different radiation therapies.
Okay. And you're going to meet her on Friday, is that right?
Correct.
Okay, so I think what you need from us right now, and I'm going to hand it back to Stuart, and Stuart and Bill have put their addresses in the chat window, or you can always feel free to, I'll pass any message along, is
okay.
Stuart, can we set Glenn up with the right questions to be asking the radiation oncologist? So she turns around and says, oh boy, this guy's smart. I better be telling him everything.
Well, you know, first thing you do would be to ask them what type of radiation are you proposing is best for my case.
Okay.
And you know, is it SBRT? Is it I'm blanking on it. You know, is it?
She talked brachytherapy. That was all she talked.
Okay. So explain SBRT, explain brachy. So take him through it, Stuart.
Okay. There very simplistically, there are a couple of types of radiation therapy. There's external radiation beam, which would be SBRT or EBO. There are different types of external radiation, the difference being how many visits you have to make to get the full treatment.
Okay. I think she was talking beam therapy. So is that what SBRT might be, is beam therapy?
Yeah, but there's proton, there's photon, there's SBRT, there's there are lots of different types of ways that they can shoot a beam at you. The real question becomes how many sessions are you going to have, are they recommending that you have? The SBRT has the benefit of having 5 or 4 sessions over a week or two, whereas other types of radiation can be 20 or more daily sessions, which is just
20.
Okay, so she's talking, okay. The question you would ask is why 20 and why not 5 SBRT?
Okay.
And then if she says, oh yeah, SBRT is an option, you ask her, what type of SBRT are you doing? Is it CyberKnife? Is it MR Linac, which is done in an MRI, which is more sophisticated? There are lots of different types of radiation, and the question that you want to ask is, which one are you telling me is best for my case? And
Okay.
then just to go back and finish, brachy is an internal treatment.
Yeah.
Where either, depending on whether it's high dose or low dose, they're either talking about putting seeds in that stay there, or they're talking about temporarily inserting a vehicle to transmit the radiation from inside, which is either 1 or 2 treatments, and then they take it out. And so it's just a different way of delivering it. If they're talking about brachy, you'll also have to ask them about, are you talking about brachy plus radiation or brachy just by itself? Because the studies show a different success ratios, or risk, higher or lower risk of recurrence, depending on which form of brachy you get.
Okay.
And then the other question, since you have 4 plus 3, you have to ask them is, do I need ADT?
Okay. Which is?
Which is hormone treatment that so there are a whole bunch of things you're listening for or asking about to get this radiation oncologist to, give you as much of their thinking as to why they're saying what they're saying, to try and separate it from that's the way they just always do it.
Okay. And I did meet with her once, and she spoke for over an hour about the different options, but this was before I had the MRI and before I had the PMSA PET scan. So this will be the second meeting with this oncologist.
Well, and again, the real focus is, I don't want to hear about the textbook general descriptions. I want you to tell me how each of these options line up for my case, given the given the biopsy, given the PSMA, given the MRI. What's best for me? What do I need to do? What do I, that's really what you're looking to get out of that doctor, to figure out if you're comfortable with making a decision, starting to make a decision to proceed.
Right. So one other thing, we really get the aspect of the Canadian system being a national health service. I certainly get it because I was raised in the UK. So
it's regional, though.
I understand it. Now, that said, we have seen guys in Canada all the way from Quebec to Vancouver who, if they advocate for themselves, for the type of treatment they want, a lot of times they can get it. The docs aren't used to having patients advocate. The docs in Canada, if you're seeing them on the National Health Service, are used to telling you what to do and you saying, yes, sir, no, sir, 3 bags full, sir. And if I don't commit to anything from this doctor, just absorb everything she says and bring it back to us, and then we can sort of start to help you in making sure. Maybe she'll suggest the best thing. I don't know. Do you have any other illnesses, Glenn, that you to be concerned with? Have you ever had hernias or anything else? Where's that good wife of yours? She can come into the picture. She doesn't have to. Hello.
Marty.
He's had a hernia, is what he's had.
I had an umbilical hernia that was repaired a year ago, quite successfully. So I'm happy with that.
That might influence your candidacy for brachy. And the other thing that Dr. Mark points out, which is an excellent point, and you have to ask, is will the sepsis affect any of your treatment choices? Really, really good point, which most of us wouldn't have thought. Right, Marty? I hope you're sitting there taking notes. That's all I
I'm
hope.
writing notes. Yes, I'm trying to keep up
That's
with all of
good.
it.
Okay. So let's make sure that that hernia doesn't complicate anything and nothing else. There are some people, have you ever had any urinary issues?
No, just frequency. Just
Well, now
crazy,
because of
crazy
this
frequency.
issue, yeah.
So this could be the crazy frequency, but if they think it's that bad, they may say you're not a good candidate for SBRT. We'd rather do IMRT because the doses are smaller, even though you have to go more often, and it can be and it can be less invasive. And if somebody who has a bad history of urinary, which could of course be down to the prostate cancer too, they may say, well, we don't think you're the best. Yeah, we have SBRT. They may say to you, yes, we have SBRT, but by the way, you're gonna have to go into Vancouver for every treatment. And you may say, well, I don't want to do that. They'll say, well, all we can do locally is IMRT.
Mm-hmm.
The biggest concern that I have from what you're telling me when she's talking about 20, and she may up that now, is that they're not thinking of doing any boost for you. They don't see any reason to give you extra radiation because of the amount of cancer you have. And the other thing, as I said, is I doubt this will happen, but don't let her talk you into focal and say, well, one side's clear, so we only need to worry about that is not the case, especially with 4+3. And the simple answer to that is thanks for the offer, Doc, but I know I've got 4+3 and I don't even want to think about focal therapy. For somebody like you with focal therapy, the chance of recurrence is going to be higher than 50%, maybe as high as 70%. So I wouldn't even think about it, even though it looks like it's all on one side. Just like Dr. Mark said earlier on, yeah, we're not 100% sure it's only on one side. What we can see is on one side.
Okay.
Okay.
I will know more when I talk to her on Friday, but I did ask her when I talked to her, because we had been looking around, and I've had a brother that had prostate cancer some 7 years ago.
Yeah.
I believe he had the heat therapy in Toronto. He traveled to Toronto, and it was not successful.
Forget about it.
Okay. And then the other thing, we're not even considering that. The other thing that we are hearing about, and we grew up in Saskatchewan, and right now the University of Saskatchewan is experimenting with the nano knife, electroporation for pancreatic cancer. I don't know how much success they're having with it.
Okay.
Now, the nano knife is in Toronto. It's not available here.
Okay. So I'm going to let Stuart address the electroporation targeted treatment, because he happens to know a little bit about electroporation.
All right, Stuart. Thank you.
I had electroporation as part of my treatment.
Okay.
And if you were even considering doing that, and there is an issue of risk of recurrence for any focal, it would be incredibly important that you only pursued this if you were dealing with someone who is very experienced and has done a lot of it. Because this is anytime you're dealing with focal of any sort, the only person you want to deal with is somebody who at a strong medical center who has a lot of history with it. Now, given the amount, again, the problem that I would have with doing it is because we really don't know how much cancer you really have. And so they could go in and do a bang up job on the targeted area. And 6 or 9 or 12 months later, you could be staring at PSA going up again because there's, the rest of the prostate wasn't treated. And so without certainty about what you have or don't have, while it could be a legitimate treatment, I don't think it's a great idea for you because we have this unknown.
Okay.
The benefit that you get out of the radiation treatment is they're going to treat the whole prostate. And so they have a chance of finding and treating the cancer that we don't know if it's there or not.
Okay.
So
Yeah,
Just
so
one-
I'll just chime in there.
Okay, Rick.
The IRE electroporation that you're talking about with this cyber knife, nano knife, whatever you want to call it, is another form of focal treatment. You do not want focal treatment. So is the heat therapy. The heat therapy can be applied to all of the gland most of the time, and the freezing, they're only applied to a part. I would not even consider it. I wouldn't even take the time to raise it with the doc, because you're just not a good candidate. Now, if there's a clinical trial like Stuart was in, where he got focal treatment plus he got the radiation, that is worth talking about, but not just the focal treatment on its own.
Okay, just for your information, Rick, in Canada, the standard of care, Health Canada does approve the nano knife or electroporation, but they don't pay for it. So the cost in Canada for it to travel to Toronto would be $25,000.
Yeah,
I'm assuming.
Forget about it. It's not even worth thinking about it, unless there's a clinical trial.
But the interesting part about it was, if they do it and it isn't successful, then radiation is something that can be done again. Whereas
But
I'm understanding.
Glenn, you don't sell it to me.
Okay.
You've got a 70% chance that it won't be successful before you even sit on that table.
Because
70%.
of the 4+3, Rick, is that what you?
Because of the 4+3.
Okay.
70% chance it won't be successful. Don't even think about it.
All right.
Okay, don't think about focal therapy in your situation unless it's a clinical trial where it's accompanied by radiation too.
Okay.
Okay, we got to move on, man.
Okay.
But we're here for you.
Thank you so much. And I must move on. So thank you so much. I am going to sign off now. I appreciate the information, and we'll look forward to getting some more information from all of you. Thank you.
Okay, and we're back here. The next meeting is 2 weeks from tonight, same time, the 25th.
Perfect. Talk to you then.
Bye-bye.
Bye. Thanks, Glenn. Fritz.
Hey,
Thank you
guys.
for hanging in there. And
sure. Yeah, I appreciate how detailed you're being with everybody. That's awesome. Super helpful. So
how old are you? Fritz, how old are you?
I'm 63, and then I'm gonna give away the last chapter of the book. I just had surgery 3 weeks ago, but I can go back and go through things methodically. But decision process was made, and I had surgery. So.
Okay. I'm sorry. How recent was the surgery?
3 weeks ago.
Okay. So do you have any of the post-surgical biopsy information yet?
No, I'm going to get that in about a week and a half. So yeah,
Okay.
I don't have that pathology. I haven't done the follow-up PSA yet. They did tell me after surgery that they felt, based on the scan, imaging and everything, that it was contained, and that they didn't need to remove the lymph nodes even though that was an option, and felt that it was successful. But obviously, we're waiting for the pathology and follow-up PSA to really know what's what.
Where did you have your surgery?
I had it at Northwestern, and it was sort of my, initially I had a local surgeon, radiation oncologist sort of options in play, but I wasn't happy with everything that was going on. So I did the second opinion and actually just sought out Northwestern for, a surgeon that had a lot of experience. And because of my Decipher score of 0.61, if I did radiation, it was going to have to be accompanied by hormone therapy. And I really didn't want to do that as a first treatment option. So that definitely pushed me toward the surgery decision.
If I can just jump in here, Fritz.
Yeah.
It's kind of a cart before the horse situation now, because you came to us, you've already made your decision and did everything. So going over your history for your decision and stuff wouldn't really help you, because you've already done it.
I didn't know if there was a group for people that have already had surgery, because I was intermediate grade and I'm not the.
Well, we have you're welcome to come here. But a lot of the guys who come here have been diagnosed but haven't had treatment yet. So they gather all the information to try to get an idea of what treatment to take. I mean, that's a weird way to say it, right? What treatment to get. But
Bill, this is Fritz. This is the right group for you to be in at this point.
Okay.
This is absolutely the right group.
Excellent.
The question we have for you is what certainly will help you when your post surgical pathology comes in to help you understand it. If you need that help, we'd be happy to do that.
Yeah, that'd be great.
But the second question is, and in this group, we do speak quite a bit about urinary issues and ED issues, and we're happy to talk about all that too. But the question is, what do you want from us?
Well, yeah. So actually, just learning, and the information you're providing is super helpful, because I got hammered hard by another support group that, hey, you totally need to do focal therapy, and this was 4 days before surgery. I mean, hammered it was an hour-and-a-half presentation, and then the moderator was presenting, yeah, you really don't want to do surgery. You want to do focal. And he even called me up after and trying to get all my diagnosis and telling me that I should call the doctor and I can cancel up to the point of rolling into the operating room. So it was really a horrible experience. So I'm really thankful for a group like this where, you provide lots of good information, but you're not hammering one way or another. And I wasn't a good candidate for focal anyway, but I guess, what am I looking for you guys? Well, I guess my two, I know fatigue, I'm just about almost 3 weeks out. So I know fatigue, it takes time to get over that. I'm in definitely the stress incontinence phase, which is, I'm okay sitting, lying, but any sort of movement, action, walking, lots of stress incontinence. So that's a pain. But I know I'm early. But maybe the question that I'm most sort of wondering about, that I haven't heard much about, is just, I know that the risk of inguinal hernias post-surgery is 11%. And I already had an existing small one. It's just a small one, fat bearing on one side and the other. And a tiny hiatal hernia. None of them are anything significant, but I just wonder, are there things that I can do to avoid making those worse?
Boykin, can you?
Yeah, I was just going to jump in. You should have, Rich, already at this point, because I've had a radical prostatectomy just like you did. But at this point, you should have been sent to a physical therapist to walk you through key log exercises and other things that you should be doing uh, uh, daily to help with your stress incontinence and things like that. Have you seen anybody like that that should be part of that urologist?
I have not actually. I mean, they gave me instructions on how to do Kegels, but I was super proactive. So I started Kegel routine, I think like at least 4 weeks before surgery. And I picked up a book that it's called, it's by Vinita Gaglani. It's not the best edited book, but it seems like the information is good, and it's about sort of advice on restoring urinary continence after a prostatectomy. So I've been doing like avoiding bladder irritants. I've been doing the walking. I've been doing my Kegels. And she does have some exercises in there, so I was going to start adding those. I think I'm far enough past surgery date that I could start doing some of that, because most of my abdomen pain has passed at this stage. So, and I'm pretty confident I'm doing the Kegels properly, because I know a lot of people do them wrong.
Okay, but I will tell you this: at 3 weeks, your inside is still healing from the surgery.
Okay.
Well, let me ask: did you have a radical prostatectomy? I didn't ask that. I'm assuming.
Yes, sir, I did, and it was a done at Northwestern.
Okay.
It was a fascia sparing sort of procedure that Dr. Kent Perry does there, sort of like Dr. Schaefer, who kind of oversees the program there. And that's supposed to help with continence, as far as preserving more of the structures.
So let me ask, when is the next time you're supposed to go back and see the urologist?
On the 20th.
Okay, so that'd be what, your 6th week? What they
Pretty
call
much. Well, close, yeah.
30
I had
days.
surgery on the 21st, so yeah, just about 5 weeks maybe.
Okay.
Yeah, I
'Cause
mean,
you need to follow that regimen, and then I'll throw my my email in there, my AnCan email, and if
Oh,
you
okay.
get any symptoms, you can hit me up. But
yeah, Fritz, Boykin made a great point. Right now, 3 weeks out from surgery, you shouldn't be doing any exercises, actually.
Okay. I
And
haven't.
then when you go back to your doctor, if your insurance will pay for it, I would ask for a referral to pelvic floor therapy.
Okay.
I did it. It helped me. I had some complications after surgery, and I did it, and it helped me greatly. So.
Okay. Yeah, definitely. No, I appreciate that. That helps.
We do have a couple of hands up here too, Stuart.
Yeah, Larry, what have you got for Fritz?
Yeah, I just sent a private message to Fritz. When I had Kegel exercises, I had someone who was expert in male physical anatomy for urinary continence, and there's no substitute for an actual coach who can see what you're doing and give you the exercises that you need for your particular whatever you're doing. So that was it.
Okay. Thank you. Yeah. Because I've realized everybody is so different with this. It seems like every step of the way, their response and symptoms and everything it's so all over the map. So yeah.
I would agree with Boykin, given the choice between real live physical therapist and a book. If you have the opportunity, at least once talk to the person and see if you think it's going to help you. Rick, what do you got?
Well, I think you're doing great, Fritz. And I'm not sure you're really giving yourself credit. You're 3 weeks out. For you even to be relatively dry at this point is terrific. It's not at all surprising you have stress incontinence. You've got to give yourself time, man. Most people, it takes you know, they're going to be using pads a good 90 days, and some people 180 and some people worse. So allow that for yourself, and, you know, don't be disappointed. Secondly, absolutely agree that a center like Northwestern, we're very familiar with Northwestern, should absolutely have referred you to a Kegel physical therapist, and they will if you ask them. And if they don't, then we have ways of taking that up. But I would be very, very, very surprised if they don't have a Kegel therapist. They can send you to somewhere in your area.
Okay.
And the third thing is, be very, very, very careful with any type of exercise. They should have told you how long to wait before starting exercise again. And, you know, usually from what I know, it's at least 6 to 8 weeks before you can put any type of strain on your abdomen. It may even be longer. I'm not sure. I did not have an RP, but there are guys in here who did have RPs, and they will tell you. But that is, if you want to get yourself a inguinal hernia, that's a quick and sure way to do it. Is to start putting stress on your abdomen. So those are the takeaways that I'd give you. As far as the other support group, look, for whatever reason, and we haven't got into it, what was your highest Gleason grade before?
Yeah, it wasn't dramatic, you know. Oh, I'm sorry.
What was it? Just what was
Gleason
it?
grade. Yeah, so I was a 3.
Were you a 3+4 or a 4+3?
I was a 3+4.
Okay. So the reason why is maybe they thought you didn't need therapy. We have done that. We've taken that approach, but it's very, very rare, and only in the case where we really think somebody's being rushed into surgery. Northwestern has a bad reputation of doing that, so they may be aware of it too. But the fact is, you are where you are now. Now we want to help you get better. We want to help you get your incontinence back, your ED. We want to make sure that you have a really good and solid post-op pathology report that doesn't need rereading. There's nothing suspicious. So that's where we are.
Yeah, I appreciate that. It's a huge help. Yeah, you know, I pretty much had made my surgery decision before I reached out to Northwestern, but, you know, the local surgeon had only done 100 prostatectomies, and sort of doing homework, I realized I needed someone who had done a whole lot more.
Fritz, with respect, we've really got to move on.
Sure. Yeah, definitely.
We can't get into the weeds here, but come on back in 2 weeks. Make sure Bill has got your email address. We'll have a meeting in 2 weeks, and we'd love to know how that post RP pathology, what it says.
All right. Thank you, guys. I appreciate it so much.
Okay. Joel, you're up. You're muted, Joel. We can't hear you. Okay.
Okay. I did come to this group soon after I was diagnosed in November of 24. So I was in this group for maybe 2 or 3 months, and then slowly I made my way to the active surveillance chat group, where I still am. I still participate in that, and I have been in active surveillance. I have had no treatment. I had 5 cores of the 12. Only one of them was a 3++. 3+4. The amount of cancer was, my understanding, very small. 20% of the tumor of the core contained the tumor, and and of that tumor, only less than 10%. Less than 10%. I don't know. I'm getting confused there. Let me just say that my understanding from the biopsy was that it was very small. I've had since I was diagnosed, and just before that, I had a MRI, and just in September, I had my second MRI, and both MRIs were almost exactly the same. They both showed that I had no signs of any lesions, and that I was in the prostate and everything around it was in very good health. My PIRAD score was 2 in both of the MRIs. Now, what has happened, and maybe the reason I've come back to this group now, is that slowly my PSA over the last 2 years that I've been getting the PSA test every 3 to 4 months, sometimes it goes up and then it goes down, but it has always stayed between 6 and 8. Well, my last PSA test score, which I just had on Friday, that I got the results back, was 10.7. 10.7. And so one of the things, and of course I was very sad. I was upset. I was thinking, oh boy, I finally have gone above that 10. And the urologist made the comment to me that she's just concerned that my PSA scores just continue to kind of go up. Every now and then, yes, they go down, but they just continue to go up slowly. And now I have a 10.7 score. So I am just trying to anticipate how to kind of perhaps bring her along with me to let me give this active surveillance time for me to understand more about what's going on. I have not had a second review of my biopsy, and I've just reached out to Dr. Epstein to see if I can get that done. So that is my primary thought, is that maybe I should come back to this group, also participate in my active surveillance, but just begin to learn more about how I should think about the fact that my PSA scores are slowly going up. And even though my 2 MRIs have been good, even though my one biopsy only showed that I have one core of 3+4, that maybe I need to consider radiation. I'm not sure that I should, but I'm not. Yeah, I'll just conclude there to see if there's
Larry, what do you got for Joel?
Has your urologist ruled out any of the other several possible causes of why you might be having these bumps in your PSA readings? There's infection, recent sexual activity, bicycle riding, stuff like that.
Well, the only, I mean, I believe I understand enough. I have learned enough about things that might, make the PSA scores go up. The only thing that I do a lot, that I do enjoy, and I've done it more over the past 7 or 8 years, is I do ride a bike when I go to the gym. Of course, I don't ride all day, but I've heard that pressure down there. So I don't know that I am doing anything to really cause that PSA score to continue to go up. That's all I can offer.
Boykin?
I was gonna say, to me, I was just trying to look it up. That's why I was slow. But I think you need to go to Men Speaking Freely, and because what you really are dealing with, in my mind, is not so much a treatment thing just yet, as much as a lot of anxiety about a treatment that's likely to come. And so I lost the specifics on when AnCan's Men Speaking Freely happens next, but I know it's on Thursday nights, and I'm sorry I didn't get a chance to find it, but I'm sure we'll find it. But the other thing I would say, offer to you is that if your doctor that you're seeing in active surveillance is suggesting that it's time to start thinking about treatment, I would take that very seriously, regardless of your treatment decision, because I've had chronic kidney disease. I'm a kidney transplant patient, and those patients go through something very similar. And when my nephrologist started recommending that it was time for me to start thinking about other ways to deal with my disease, they were spots on and lead me along. And then the same thing with my own PSA. So if you have doctors that are suggesting to you that it's time to start thinking, then I think coming here and learning and listening is what you ought to be doing. But I definitely think you should be maybe checking out Men Speaking Freely.
Okay, thanks.
Great. Well, come on back and tell us what's going on.
Sure.
Albert, how we doing?
I'm good.
We lost you. You're on mute.
Got it. Okay. Yeah. So, I'm sorry, I'm still deciding, even though I keep saying I've decided. I think I'm going to do Kishin at UCLA. The one thing that came to mind that I wanted to ask about tonight was if something comes up in the future, I could go up to Mayo in Phoenix and do protons or IMLT with Dr. Vargas. And then if something comes up in the future, I'd be closer just to drive up to Phoenix from Tucson, 100 miles away, rather than flying to LA for UCLA's system. But it seems like UCLA would be better, like a better system if I need follow-up in the future, like salvage therapy or something else. I don't know what might come up. And I just wanted to see what people thought about that, because I know some people, like Bob, he's going from Georgia up to Sloan Kettering, and if he has to follow up with them, that's a long trip, but it's worth it to a lot of people do this traveling thing to a center of excellence that they think is going to be the very best one for them. And then they just deal with it as that comes.
Well, I would spend a little bit of time worrying about what might happen down the line. And, you know, you feel good about Dr. Kishon and UCLA and Marlinek. Don't overthink what happens if it goes wrong to the point of hesitating from, you know, pursuing the initial treatment. It could go right.
Right.
And you're done. And it becomes boring. But you'll never know unless you get there.
Yeah. Yeah.
Yeah, and also that's kind of a personal decision, Albert. I mean, if you can, I mean, there's factors, right? If you can afford, and if you think in the future you're going to definitely be able to afford to travel back if there's an issue, fine, go to see Keyshawn in LA and let him take care of you. Again, one of the best docs in the country, right?
Yeah.
You can't go. You probably. I'm not a doctor. You probably can't go wrong with Dr. Keyshawn, right? If in the future you have the ability to travel because there's something and you want to follow up with the same doc, then that could be your decision. But I know there are people in this group can travel to get treatment, but there's also we deal with a lot of men that can't. They just financially or for other reasons they can't travel somewhere far away to get treatment. So
Right.
I mean, in one way you're lucky or you're blessed, and so.
Yeah. Okay.
But really, I mean, we've given you all our opinions on the best docs. I think you made a good decision. I keep telling you the same thing, man. Pull the trigger.
Yeah. Okay. Well, that's it for tonight. Thank you very much.
Okay.
Appreciate it.
Brian, how are we doing? What's up?
I think I can just pass tonight. I got an MRI last week and it was clean, but I think I'll organize my notes a little bit and come back in 2 weeks, and that way I can.
Okay.
Are we having this on? It's on a Memorial Day. It'll be on Memorial Day Monday.
Hey,
Yeah.
good question. It's on our calendar.
This conference will now be recorded.
Yeah,
that was my bad.
That's
sorry
all right, Rick.
I went to press my camera. Yes, we never we're like the post service, you know, postal service. We go on in all conditions and all days and all weather. The only days we usually don't, I think, is Christmas Day. We do make an exception for Christmas Day, but otherwise we're always here. So there will be a meeting, even if all my moderators are busy and I have to run it. But there will be a meeting on the
25th, yeah. That's a holiday for my company, so I'll be off. So I'll be available.
Thank you.
Okay, so come back in 2 weeks.
Sir, be here.
Mark, you're up.
So just a quick question. I had the HDR brachytherapy done with Dr. Chang at UCLA 3 months ago, and I'm scheduled to have the first blood draw done in 2 weeks. And both Dr. Chang and Dr. Scholes have told me not to worry about the first test much, whether it goes down or even slightly up. And I just wanted to get the group's feeling on how I'm supposed to process that information. Is the first one just preliminary to start getting a baseline? You don't really worry about it, or should I be more concerned than they led me to believe?
It's really, I mean, you have to get a baseline, right? So you got to get that first one. So whatever it is, you're going to compare that to the second one.
Well, Mark, remember.
My opinion would be don't worry about it.
Mark, remember what you're talking about when you're talking about radiation therapy, and brachy is radiation therapy. That is not an immediate, that's not an immediate end to the cell life in the prostate. It's something that can take 6, 9, 12, 24 months until it reaches its point of nadir. So, you know, you're at the beginning of a marathon as far as watching your PSA trend. And so there really isn't a number that I could imagine would come back that would make either of your doctors sit back, unless, you know, it was just a ridiculous number off the top of the chart. You know, it's going to be the trend over the next 6 to 9 months that really what you're going to be looking at.
Okay.
Anybody else? Anybody else who's been through that have comments?
I mean, I certainly do, but it was a little different, Mark, because I also had hormone therapy, which artificially suppresses the PSA. Most people, I don't know the percentage, but I'm guessing 50, 60, 70% of people do see a bump in their PSA, meaning it goes up before it goes down. So it may well be several months that your PSA lingers around a fairly high level. When I say fairly high, you know, it could come back in your first test in the ones, 1.4, 1.5, lower, higher. But the question is watching it over time and seeing where it goes. Mine, when I did come off the hormone therapy, climbed for 11 months and then it fell. And that's what my guy told me. So I think the advice you're getting from Dr. Chang and Dr. Schultz is solid. You know, don't be too anxious. Easy to say, hard to do. I really wasn't that anxious, so I do have the T-shirt, but I figure it is what it is, and we'll go from there.
So I appreciate that. That obviously is confirmatory. If it does go down, and let's say significantly from where it was prior to the treatment, is that usually a very good sign that the treatment was succeeding? Or is that also too early to tell because you just have to wait and see how it plays out over the next 9, 12, 24 months?
Well, you know, we'd expect your PSA to be lower than it was before you went in for the HDR. What was your PSA?
8.7.
Say that again?
8.7.
8.7. So we'd certainly expect it to be lower. If it's higher, we got a problem right now. So, you know, we definitely expect it to be lower. How much lower? Don't know. I'm guessing that if it's below 4 or less, you're in good shape. But that's just my gut. That's what I would see. But, you know, it could be 5. It's done something, and it could be 1 point something as well. But don't put a lot of weight on that first one, which is the confirmation I think you're looking for here.
Absolutely. Thank you.
Okay.
Anybody else have experience of PSAs right after, immediately after radiation treatment in this room? Who else had radiation in this room? Anybody? Or are you all?
Tim?
I did.
Okay, Tim, what was your first one?
My first one, pre-treatment was 6.6, and my first one, 5 weeks later was 5.47.
And where is it now?
1.49.
And how many?
At 18 months.
At 18 months. So there's a good example, Mark. That's a really good example. Anybody else? Any other radiation peeps in here right now? I mean, Stuart, what was your first one after? I know it was focal plus radiation. What was your first one?
Mine went down way fast.
Okay.
And yeah, I think I was 3 point something before the treatment. It was 0.59, I believe, was my first test 3 weeks post. But us in the clinical trial have this weird thing going on where it appears that the combination treatment actually accelerated the drop in PSA beyond what the doctors had expected. So when you talk to Dr. Nagar about what to expect when you have SBRT alone, it's a slow, gradual drop.
Anybody else? Do I have to keep picking on people that I know had radiation?
Jim raised his hand.
Go ahead, Jim.
You're muted, Jim.
Yes, I started ADT, Orgovix, and radiation was 6 weeks later. But pre-treatment, it was 6.4 PSA. At the beginning of radiation, it was about 3.1. And a month after radiation, I had 44 treatments of IMRT. And a month after, it was less than 0.01, and it stayed there. I'm 17 months in. I have my next test tomorrow.
Okay, well that's a good result. And of course, the problem when you have hormone therapy is it kind of masks things. And a lot of times when you finish the hormone therapy, it can creep up like it did for me. In your case, it didn't. But all right, so there are a few examples for you, Mark. Do you feel any easier?
Yes, thank you.
Okay. Larry, what's up? You're muted, Larry.
There we go. I just got a notice from the NCCN, National Comprehensive Cancer Network, saying that they're looking into changing their recommendation for when to stop PSA testing. As you know, they recommend 70 or 75, and because too many people get rising PSAs and they go on and have unnecessary treatments or unnecessary additional testing and procedures. But they're looking at that and thinking about interpreting these tests more intelligently than they have been in the past. And if you like, I can put a link to their news release in the chat if you want. What do you think?
Sure, go ahead.
And throw that in there. Appreciate it.
Yeah, no, of course, the question is are they making a distinction between those who've been treated and those who haven't?
Not sure. I haven't read the whole report.
Yeah, let's take a look. Bill in Virginia, are you still with us?
Yep, still here.
Okay, so it's a lot of boxes on the screen. What's up? What can we do this evening?
Well, I got a second opinion from Dr. Epstein about 10 days ago, and it was a bit different, worse. I had one 4+3. He thinks there's another with 80 or 90%. Grade group 4. So today I met with the surgeon and a radiation oncologist to talk about the options and the timing. So I did schedule surgery. That's it.
Okay. Was this the first time? Was today the first day that you were talking to both of them after?
It was.
Second
this
opinion?
is the first. Yeah, this is the first time I got a little more detailed explanation about what the radiation oncologist would propose. I don't think Dr. Green's going to have a different opinion. It would have been a lot more interesting under my previous 3+4s and near the margin and getting her opinion on that. But 2 4+3s, and one of them, Dr. Epstein said it's probably 4+4 because it's 80 or 90%. So there's really no reason to wait.
Okay, you're comfortable with where you're at?
I'm comfortable with what Dr. Epstein said.
So I think the most important thing for you to do at this point, Bill, if you're comfortable with what he said, and that clearly indicates you need treatment, how recent was your last biopsy or MRI or scan of any sort?
Yeah, the biopsy was a month ago. The MRI was in October.
Okay. So, and is there any indication from Dr. Epstein or Dr. From Dr. Epstein or whoever read the PSMA report that there's anything outside of the prostate?
Dr. Epstein says there may be the start of I don't have it. I should have it right in front of me.
Extracapsular extension.
I think it's not that. He noted small cell cribriform.
Okay.
The pathologist said just cribriform, but he refined it a bit.
Okay. So he sees maybe possible little small cell cribriform, but other than that, nothing outside the capsule.
Doesn't think so.
Right.
We did order a PSMA PET today.
Have you had a PSMA PET before?
I have not.
Okay, so only an MRI before.
Right.
So I thought you'd had a PSMA, but I think getting a PSMA PET is very smart if you're close to a 4+4. And how old are you? 63? 62. I would probably pull the MSKCC nomogram based on Dr. Epstein's report, fill in the numbers, see how likely it is that surgery alone will not be sufficient. I probably would tend to surgery at that earlier age, and if there are some issues, but it's certainly not committed. Radiation is an equally good option. So, but I definitely would run the MSKCC report and then basically go with your gut, because it's 6 of one and half a dozen of the other.
What was interesting was the radiation oncologist tending towards external beam and brachy together, but he would not do SBRT, and I don't really understand why. But so he's talking about 25, 25 sessions.
Okay, so that's interesting because that tells us that he thinks that there's more there than what he sees initially. So he wants to give you the boost. I think that's fine. I know that Mac Roach in UCSF prefers to give that boost with SBRT. So he would do SBRT plus IMRT, and that's a way to go. But you have to push them, and as I've said to you before, I might even go and get a second opinion at this point. If you decide you want to do the radiation, get a second opinion from Kurt DeVille at Sibley. He's really good.
Are you familiar with Daniel Kim? who's at Innova now. I guess he left. Maybe he was at Walter Reed before. I'm not sure.
No. But if I was going for a second opinion in your area right now, I would go to DeVille, Kurt DeVille.
All right.
At Sibley, because he's really good. He's experienced prostate cancer, radiation oncologist, and that's where I would go and ask him about the combinations available, and ask him to compare and contrast between SBRT and IMRT versus brachy, presumably HDR, because very few people do. They may still do seeds at Walter Reed. I had seeds in IMRT.
He said it would be HDR.
HDR. So compare and contrast between HDR and IMRT or SBRT and IMRT, and how much hormone therapy did he say you needed?
He thought I should take a Decipher, but that would take a month, and he's also talking about being able to start soon, but he said depending on what would come back, 2 years versus 6 months.
Kishan has this paper that says you don't need to start it before, but there are some other very, very respected GU medical oncologists who don't accept that paper and think it was flawed. I can't tell you. If it were me, I'd start it before. I don't think it's going to make that much difference if you wait and start it or if you don't. There's also that other test. What's that AI test you can order?
He mentioned something. He mentioned that too. I can't recall it.
Guys, somebody in this group should know that. What's the name of the AI?
Artera.
Yes. What's it called again?
I think Artera AI.
Artera.
Yes.
Artera AI. Yeah.
I look at slides, I think, for that one.
I'm sorry?
I think they look at slides versus biopsy for the Artera one.
I'm not sure what the input is, but that is the one. So I would run the Artera AI because it's specifically focused, more so than a Decipher. It's specifically focused on whether you need hormone therapy or not.
Yeah. I mean, I think I already have a clue as to how aggressive this is. So.
Well, if it's aggressive, you shouldn't mess with it. And I know we've been talking to you for a while, but I really would encourage you to decide which way to go, run that nomogram. I mean, the last thing we want to see is you run into surgery and then you find out that you've got to do hormone therapy and radiation afterwards. Is that right, Mr. Franklin?
That is correct.
Want to say anything about that?
Did you want me to elaborate? Not really. I'm sorry.
Yeah.
Yeah, Bill, I'm sorry, guys. Check the chat. We put the Artera stuff in there for you.
I appreciate it.
Okay, Bill, you good or the questions?
Nope, all good.
Okay, Tim. Thank you for hanging in there.
Yes, just in the context of the email that AnCan sent for this meeting, Stuart commented that he wanted PSA input and variations by some of the participants. So I'm an SBRT patient. I'm 18 months post-treatment, and I've had 4 PSAs from Moffitt Cancer, and every one of them has trended lower. And I'm currently at 1.49. I started at 6.6 before treatment. But in between, I had a couple of PSAs from independent labs. One was annual physical, and one was an impromptu PSA at a health fair, and those showed bumps or bounces. And I think the point here is that you're going to get variations from one lab to another, which most of us know. And as far as Moffitt, where I'm being treated, is concerned, there has been no bump or bounce, because every time they've tested me, it's gone lower. So,
did you take ADT?
I did not.
I get, that sort of goes to the point of it could go up, it could go down. It's not, while it's a strong measure for post-treatment, it's not perfect. And, if it, and again, it's the size of the movement. My friend went from 0.3 to 0.4, and that's a rounding error.
Yeah.
So, so everything in context, and, in almost any circumstance, the doctor's response is going to be, let's see what the next one says.
Yep. And on that note, I'm scheduled for my next PSA in 6 months.
So, it's sort of like a rite of passage. You sort of accept that it's going to happen, and you don't get too hung up about it. Hopefully, is the best way.
Yeah. It wasn't clear. It wasn't clear to me in your comments, Stuart. Did your friend have RP or radiation?
Radiation. He's actually in the same clinical trial that I'm in.
Okay.
So he had a combination of focal plus radiation. And his like mine came down very quickly, and he has this. I hesitate to even call it a bump. When I last talked to my doctor 6 or 9 months ago, and his comment, again, he was going by the standard. If it goes up 2 points from wherever it is, then we'll start to be concerned and consider it. Short of that, he really, he wasn't even going to pay it much attention. So, but we'll cross our fingers that you have another good PSA. It sounds like your Moffitt numbers are, pretty much textbook for what the pattern you'd see on MR Linux. So it sounds like you're in good shape.
I'm really quite a negative kind of guy, skeptical and cynical even, but I don't have any complaints at Moffitt. I can't find anything to complain about that. I thought I'd throw that in there.
Well, that's a good recommendation. Call the communications department and tell them
coming from me. Yes.
You tell them volunteering a testimonial that I can find flaws with almost anything, and I can't find one with you.
I've tried.
Anyone else have any comments on PSA tests and movements they wanted?
I have
SBRT.
I have one. I mean, mine is a little unusual because mine's kind of low. It's 1.93, and I just have bad features confirmed by the decipher. So I'm going to be on ADT probably in a week. I have no idea really what to expect for PSA, whether it's going to go Probably go down a little bit, but it's not that much to go. So I don't really know what to think actually about expectations on that.
I think, I think they correct me, Rick, Bill. The expectation for ADT is it's going to go down.
Just a little bit. that I guess is ADT, but I'm just like, it should be 0.1 if it's,
Okay, so it's once you start taking ADT, first of all, it depends on what type of ADT you're taking. If you're taking an antagonist, then it should go down right away. And within about 2 to 4 weeks, I would say within 3 weeks, hopefully it's going to be down around, your testosterone is going to be down around 0, not 0, 8, 9, 10, somewhere in that range. And your PSA is going to drop. And with your PSA being low in the first place, it probably will drop fairly low. I don't think you need to, for you in your situation, I don't think you need to put too much weight on it. What you're concerned about is the combination of the ADT plus the MR-Linac and where that leaves you. And at the end of the day, will that leave you, if your PSA right now is only 1.4, then hopefully it's going to leave you at under 1. And then we're going to watch and it'll stay there for a while and maybe it will bounce up, but maybe it won't. But if you are going to worry for the next year, 18 months about every PSA test, you're going to make yourself nuts, Steve.
Yeah.
I mean, you are. I mean, you just got to accept this is, you've been so careful over the treatment decision. You've done all the right things. You're making all the right moves. And at some point you've got to, put it in the hands of the Almighty or whoever you believe in or don't believe in, or the Buddha, and then go from there. I
have. I mean, it's Orgovyx, by the way, that I decided on.
Okay, so the Orgovyx, if that's what you're starting on right away, should drop your PSA pretty quickly within the first 2 to 4 weeks.
Okay.
Yeah, Jim is raising his hand, his physical hand, not his virtual hand.
Just a comment. I started Orgovyx Christmas Eve of 2024. So I'm in my 17th month. And following radiation a year ago, my PSA has been less than 0.01, and testosterone has been less than 10.
Right.
So that's for the past year.
Right, and that's what we would expect, Jim. That's exactly what we would expect. Do you remember how long after you started the Orgovyx, your PSA, it took your PSA to drop?
The only information I have is it was about 6 weeks after I started radiation. And at the beginning of radiation, it had dropped in half, like from 6.4 to 3.1.
Great. Okay.
And then a month after radiation, it had dropped all the way down.
All the way down. So that's helpful to Steve, except Steve isn't going to even give it 6 weeks before. He's taking it a couple of weeks, he's taking it maybe a week, 2 weeks early, and that's it. And we don't know, Steve. I mean, don't expect, miracles and immediate reaction. This is still your body. You have to respond, and everybody responds differently. But I don't even think it's worth, I'll be honest, I don't think it's worth even considering.
I'm probably more concerned about what happens in 6 months when I go off it. I mean, based on what you saw, it's going to go up a little bit, right? And then then that's more the real situation.
Based on, in other words, when you say I'm concerned, what is the it? The testosterone, the PSA, what are we talking about?
No, it's, I mean, I know testosterone. I mean, mine's actually quite high, so I expect it hopefully to recover pretty quickly. But I'm just wondering, you know, okay, Orgovix ends, that suppression is done. It's going to probably go up somewhat. You know,
what is it? The PSA?
The PSA, yeah.
Ah, okay. So with the Orgovix and the radiation treatment, we would expect it to drop, not go up.
I know, but I'm saying afterwards, 6 months. You know?
Okay, so after the 6 months, it will after the treatment period. I mean, there is no how long are you going to be on the Orgovix for? 6 months?
6 months, yeah.
At the end of that 6 months, your PSA should probably be 0.01. Most likely, if it's effective, just like it was with Jim. And then because your testosterone is suppressed and you've had the treatment, it won't go up, it'll go down. We might expect a bump, but that bump can take 18 months. And it could start to go up 0.01, 0.02, 0.03.
I think
0.04, and then you start worrying, and then it turns around and it comes down again.
Yeah. Okay. You know, like before, I think I had anything, it was about 1.5. So you know, that's sort of maybe no cancer. I don't quite know,
but. Albert, your hands up?
Yeah, Steve, I was wondering, you're going to do the MR Lineac with Kishan. Are you going to also do some sort of a boost, and might that affect the PSA levels?
No, you know, I originally I went to Stanford and they were proposing a boost with IMRT 13 sessions, Reiki boost, and then it was a long path. But then I went to Keyshawn and he was pushing ADT at the time before I got Decipher, and I didn't want that, so I went to Chang because he said, oh, you can get HDR, no ADT, and then I got a bad score in Decipher, so I said, forget HDR. I think I need to do SBRT. I don't want the, you know, one, I know I have to take ADT based if you believe in Decipher, which I do, and then number two, why have the invasiveness of HDR if it's not really going to benefit you? So that's how I ended up there.
Yeah. So you'll do 5 sessions of MR Lineac and no other IMRT?
Correct.
Right. Okay.
It's pretty basic, you know, everything I've heard done. I mean, I've researched the shit out of this stuff. I'm tired of even thinking about it, actually, but I think I'm kind of, you know, in a good place. I think I've done as best as I can, honestly. I start next week. I'm flying on Friday.
Great.
Nope. Okay. Good luck.
Thank you.
Safe travels.
Thank you.
And we look forward to hearing from you 2 weeks if you're in, or otherwise.
Yeah.
After that.
Right in the middle, right before.
And you know, that it hopefully becomes boring very quickly.
I'm hoping. I'm just more afraid of ADT than I am of radiation, actually.
Anybody else? Otherwise, because we're sort of over our time tonight. We got through everybody, so I think we made it. So if we're good then, Thank you, everybody, for coming. And 2 weeks, we will see you again.
See you guys. Nice guys.
All right, everybody.